John, thanks for that wonderful introduction, and I'm delighted to be here, see everybody bright and early and slightly better weather than we were having in Baltimore when I left. So I'm going to talk about something in the next 30 or so minutes, chest pain, which is a huge, huge topic. It's really not possible to cover it entirely in 30 minutes, so I'm going to pick and choose a little bit, but let me just make a few comments. I do not have any disclosures relative to this talk. So it is such a big topic that it is the number 2 cause of presentation to the ER after abdominal pain, at least in a lot of surveys. So this is a huge issue, and the differential diagnosis is wide. So I've listed from a table, and you can find all sorts of different tables, a series of different causes, and you'll see that many of these, for instance, chest wall syndromes, which is listed on the right, do not really impact imaging in any particular way. We have nothing to say about that. So I'm going to pick and choose some of the ones that we do deal with, and some are also so obvious to chest and general radiologists, such as pneumothorax. We don't need to review that in any great detail as well. So what we're going to do is talk about a few that I think may be beneficial in terms of discussing. And one of these is pulmonary embolism, which I do not believe is elsewhere in the program, so I wanted to at least cover that in some detail. This, of course, when you think about pulmonary embolism, it's not really a disease in and of itself. It's part of the whole VTE complex, and that includes DVT. So PE is really a subset of that. It is a real problem in hospitalized patients. It's the 3rd most common cause of death. If we think about it in the ED setting, it's not as common, but we know very well that we see PE quite frequently in the setting of hospitalized patients, in the setting of ED patients. Huge numbers per annum. About, say, 2/3 of patients with DVT have PE, and at least 50% of PE is asymptomatic. So it's obviously a huge issue. Clinically, of course, over the years, multiple different scores, attempts to stratify have been promulgated, and you can see this one, I think everybody's familiar with the Geneva score, based on age, based on previous history, based on pain in the legs, let's say, based on malignancy, hemoptysis, and you can then stratify patients into, whether they're low risk, medium risk, or high risk. They can also go a step beyond that if you know a little bit about what the patient is presenting with in terms of symptoms, heart rate, et cetera, BP. You can stratify a severity score. So these are all clinical scores that exist out there, and at your site, you may use one or the other. So I don't want to focus tremendously on that because, and then D-dimer, of course, in the ER is frequently used. I'm not a tremendous fan of D-dimer, and partly it's because of what's in yellow here. The specificity is actually quite low. We used to joke for a while because we had a streak going, D-dimer positive equals PE study negative. So it is possible, they're always having D-dimers that are positive and we see negative. Now, that's probably overstating the case. Bottom line is CTPA and VQ scan are the primary techniques. And so if we look at them side by side, and obviously CTPA is number 1, but VQ does have a role, and I'm going to talk a little bit about that briefly. If you look at them side by side, you see that if you use just standard planar VQ scan, CT actually has an advantage, but in general, they match up relatively closely, but VQ scanning is a lot less convenient. So that's the pendulum has swung in the last decade or a couple decades over to CTPA. Now, I wanted to just mention this before I go in. This study isn't necessarily even a CTPA, but the other thing, though, to be aware of, let's say you have a chest, just a standard chest CT with contrast, or you have even a non-contrast. If you see the finding on the left, so the truncated cone or truncated pyramid, little bubbles, you may or may not have that. Look if you have any kind of contrast here, because this is a sign of an infarct. And I think I do see people mistaking pneumonias for infarcts, not infrequently, so beware of that. The other thing is, we can talk about false positives. And that would be this sort of situation where you look and it looks like there's a PE, and this is actually a mucus plug. So you have to be careful about certain things like that. Another pitfall that's a false positive is the so-called, and this illustrates it well, the SVC is opacified, and so is the aorta. But what happened in the pulmonary arteries in the right heart? Well, in this case, this is called transient interruption of contrast in the pulmonary. It's a mouthful in the PA. And it's attributed to a Valsalva maneuver. And basically, you're sucking up non-opacified blood from the IVC into the pulmonary system and making it appear as if there's a filling defect. And it can be much more subtle and tricky than this. So you can see little blobs that make it really look like PE. Here, you would just get a non-diagnostic study, and you'd be wondering why. So, tell the patient if you have to repeat it, don't do a Valsalva, and you may do a little bit better. All right. PE, of course, the CTPA is valuable for alternative diagnoses. And so here's a study that goes back a few years, and you can see that they found 24% had PE. And this is not what we see today. In the ER, it's probably 10% or less. Depends on, where your ER is, but it's a low rate. It's not 24%. But the study does show a whole host of alternative things that you might find, such as pneumonia, such as tumors. And this is, in their series, they found this range of things. And so, you look at this, and this patient had a PE study, CTPA, and you can appreciate that there's, at least in the part we can see, and it was true throughout, there's no PE, but there is a sizable, or at least a small to moderate left pleural effusion. And if you look, this patient had lymphangitic tumor due to breast cancer. So it's a lot of other things. The patient has a mastectomy, if you look back on the left-hand slide. All right, let me then talk about alternative techniques. Pulmonary angiography was a technique that was used 30 years ago. It's almost never used, certainly for this purpose. We're going to talk about VQ scan. We do use ultrasound, compression ultrasound or leg ultrasound. MRI, I'm just going to mention briefly because we have on occasion used that as well. So let's talk about a situation where you might want to use a VQ scan, or at least think about it, and that is in the pregnant patient. This is a study from some years ago, but it's an older technology, but to my knowledge, there hasn't been a more recent study, and this study highlights the point that in the first trimester, the pregnancy, the risk to the pregnant patient is equal, basically, and this is a radiation dose, I should say. The radiation dose is equal, and in the second trimester, because of the fetus getting higher, it doubles. So, if you're going to think about doing a VQ scan, you're going to want to think about it later during pregnancy. The other thing that happens is that you get hemodynamic changes like increased circulation, and that's going to dilute contrast. So that's another reason you might want to think about VQ scanning. And it's not absolutely necessary, but it is something to think about. I will say, though, that the level of fetal neural injury, even in the later stages, is not considered to be substantial. So those are, several points. So there have been a number of studies that have looked at, pulmonary embolism in pregnancy. And so the choice should be basically they found it to be even, as I showed you on the initial slide. And so the choice should be based on whether there is other concerns, like the possibility of alternative diagnoses and so forth. And there's been a statement, which I'll draw your attention to, that has looked at this very issue. And essentially, what they recommend is if there are symptoms, get an ultrasound first. And if there are no symptoms, get a chest x-ray first. If the chest x-ray is abnormal, do a CTPA. And if it's normal, then you would go to the VQ scan. So this is the pathway that is recommended. Just to show you what an MRI would look like in this case, you can see we can do MRI. It's just more inconvenient. It depends where your MRI is located. So this would definitely be a third line in a patient with severe allergies. where VQ scanning is not available or is non-diagnostic. And you can see in this case, the arrow is just pointing at a PE, and there's actually RV strain here, which we'll talk about in a moment. You can also reduce, in order to improve these are some things that you can do to improve your PE. Your PE study, one thing is to reduce the KVP. We know that as we reduce our KVP, we get closer to the kH of iodine, and that's going to increase the attenuation for exactly the same bolus. So if it's possible, use a lower KVP. It's going to depend on habitus. You can, if you have a dual energy scanner or a dual source scanner, you can do the same thing. So this is an example, and the benefit here is you not only get the conventional imaging, but you get these maps. This is an iodine no water map, and you can appreciate that in this setting, you can actually see a dropout of iodine. This is sort of like a perfusion map, but it's not really a perfusion map. It's just an iodine content map. And that would be an additional indication that there's a lack of perfusion. And this is just showing an example of how using dual source, dual energy CT can help you. So here's conventional, and you can probably make out a PE, but it's certainly a lot easier performed when you go to the 50 keV study, and you can appreciate clearly there's a PE right here. In retrospect, perhaps, but much easier. And this is just by post-processing the dual source, dual energy kind of data. CAD is also useful. This is from a study we did a few years ago, and you can see CAD picks up PE where you might miss it, particularly as in this case, where there's other things going on. There's clearly some consolidation at the bases, and it's easy enough. The contrast bolus wasn't the most wonderful. So it's easy enough that this was missed, actually, and the CAD picked it up. We are using CAD today, or AI now. It's probably not a fair comparison, but we are using an AI clinical tool routinely today, and I have found it to be quite useful, actually. Picks up subtle things, as in this case, and here's my impressions of AI for PE, and that is that it is highly reliable. I actually find it most useful in the negative. That is, I've looked, I always try to look first. I've looked, and I find that I don't see anything, and then I look at the tool, the AI tool, and I'm much more confident. I mean, it's speeding me up. So I say may save time, but the reality is it's definitely saving me some time. And my experience with today's tools is that they're actually pretty good. But you can have false positives. So here's an example of a patient who the machine picked up 2 PEs, but in fact what this is it's a chest tube with grunge in it, and that is actually the quote-unquote PE. It wasn't really a PE. Okay. So the other thing is you can move from the anatomic into the functional and look at CTPA for prognostic value. And so in this case, we would be using right heart enlargement as a tool. Now, early on when this was first developed, it's been now a couple decades, the thought was we had to do 4-chamber views to do this. Not true. And here's just an example. Qualitatively is, in my view, sufficient. So if we look at this study, here's a baseline, just a chest CT with contrast. Patient comes in acutely, and you can see has not only saddle embolism, but clearly has RV strain. And you can measure it, but there's no, I also use the fact that the septum is flattened here. So it's not just the greater than 1-to-1 ratio, it's also the septal flattening. And then they thrombolyse this patient, and you can see it's improved, although perhaps not quite normal yet. So this is a study comparing different ways of assessing predictive PE severity. And you can see that, without going into great detail here, that the qualitative assessment did quite well. And so that's actually what we do, trying to balance the amount of time we have and the information that we can derive. Okay, so that's a quick run through PE, going through multiple different parts of it. Now I'm going to talk about the acute coronary syndrome. And, when I talk about this, this is something we do as well. And the idea is assessing the coronary, so that's really what I'm only about, of the patients who come in with rule out ACS, only about 10 or 15% have them. And yet a lot of patients do get admitted for this to rule it out. And so there's what I call a gap, a 30% gap between those patients who have it and those patients who, who are admitted without, in the end, a real necessity. So if we look at the amount of money spent, this is a huge amount. And so the challenge for CT in this context has been to speed the workup, improve the accuracy. I like to say we have the ACS diagnosis triad. So that's the history, the physical exam, which you can see I've eliminated because we don't do it anymore, and the ECG, cardiac enzymes. This is the triad. So where does imaging fit in? Well, I think when you think about ACS, there's really three groups. There are different scores out there, the heart score, this score, that score. But the group one is the patients with clear ACS. No role for imaging, non-invasive imaging in this, as I put up here. That's got to go to cath. Then there's the opposite. There's no role for imaging here because they can be discharged safely. This is the group that we're targeting. It's about 40 to 50% of patients. Large group, what do we do with these? And this is where we can actually make an impact with imaging. We have a whole panoply of topics or of different approaches that we can use to try to evaluate this, ranging from, most of these are actually functional. The one, of course, I'll focus on is coronary CT. But if we look at these, the number one competitor for CT is radionuclide perfusion imaging. That's the one that's done the best. So if we take that and compare advantages and disadvantages between perfusion imaging and coronary CTA or CCTA, as I've abbreviated it here, you can see that CCTA basically has has a big edge. A lot of them are practical things. You don't have to move the patient from the ED suite to nuclear medicine. The hours of availability are better. We can see lots of things that can't be seen by nuclear studies. The specificity is a problem for both of these because we have blooming on CCTA and nuclear perfusion has some specificity issues. But the justifications for this have been pretty strong, including rapid scanner technology, proximity, as I mentioned, the ER. The fact that ER physicians are comfortable with using CT, some people would say too comfortable, if you think about pulmonary embolism, for instance. But nonetheless, and then there's also this fact that reducing ED cost is perhaps a benefit. And in appendicitis, that's been the case. Now, I just want to mention that one of just for a couple protocol slides here, we can use a dedicated approach or we can use what's called a triple rule. And I think everybody's familiar with the comprehensive or triple rule out approach. It's the triple being, of course, ACS, pulmonary embolism, and aortic dissection. Not necessarily the best term in a sense because we can rule out many other causes of chest pain. The protocol for these two different approaches, coronary CTA, I think everybody's familiar with, is just a limited view of the heart, and you may or may not reconstruct broad field of view axially. We do. Triple rule out is going to be a stem to stern sort of approach. Either way, it's a single acquisition. We just recrunched the data if it's a triple rule out, first as a coronary and second as a more general PE type study. What are the advantages and disadvantages? Well, the triple rule out is a more comprehensive study. But there are some significant disadvantages. You may have lesser spatial resolution. Radiation can be a big issue because it's related to the z-axis. So those are all things, and more contrast can be a bit of a problem. So, these are things to consider. And in a sense, we've tipped towards the coronary CTA rather than the triple run doing these for that very reason. So the coronary CTA is going to give you a look on the left, which is kind of a muted right ventricle look, whereas the triple rule out is going to be a blasted right ventricle look. The left is going to look the same either way. And that's, of course, because with the triple rule out, you want to see the pulmonary arteries as well. What about the radiation doses? Well, I mentioned that, and there are ways to reduce it. You can lower KV. You can do depending on the scanner you have, you can do a high-pitch flash mode, this is a study we did, and we got the actual dose down to 1.45 millisieverts on average. You can see that even some of our patients that were able to do 80 kV, we got down below 1 millisievert, very low dose. So we're able to actually play around and reduce the dose, but nonetheless, we're going to prefer coronary CTA in most cases. And the reason is really in this study, which looked at some of the, the benefits and risks, and you can see that there was a higher non-diagnostic image quality, radiation, and contrast doses. So their conclusion, which I agree with, it may be value in selected patients, but it shouldn't be used indiscriminately. What are those selected patients? What are those selected patients? Well, this is probably the answer. And the selected patients where you might want to consider triple rule out would be the ones that have an overlap between ACS and PE. So if you've got some kind of, and this would be a clinical call, if they think, well, we're not sure it's PE, we're not sure it's ACS, that's the group where you might want to approach it. And this is why. You can see this patient had negative coronaries, and you can appreciate that there's something at the edge of the film, which we reconstructed, and you can see there's a PE here. Negative coronaries, positive PE. It was a triple rule out, hence we caught it. If it wasn't a triple rule out, poor opacification in the pulmonary arteries, don't know if we would have caught it. So our chest pain protocol has varied over the years. What we do generally is, during the day, full bore, and we have trainees at night. And then, as I mentioned, we're going to stratify towards the low to intermediate risk patient, the group 3 I mentioned earlier, triple rod versus CCTPA, depending on whether you're thinking PE or not. And then I'll just throw in a couple case examples and make a point or two. So this is a patient who came in and then had a negative coronary, and you can see the LAD. I didn't show you all of them. And then about 6 weeks later came in again, and they didn't realize that the study had been done, the previous study, and this time had a cath. And I'll stop it there just to show you it's negative again. So was the second study necessary? Was it necessary? What is your warranty in the ED when you have a negative coronary? And the answer is 2 years, at least in this study. So if you have a negative coronary CTA, you've got a 2-year MACE, cardiac event-free warranty. And that is actually quite powerful because you do not have that when it comes to nukes. You don't know. The next day, it might be, the finding on nukes could turn from negative to positive. That will not happen on a coronary CTA. So it is actually quite powerful that way. Another thing that, we run into with any technique, but, here's a 2-vessel positive disease. Here's the LAD, you see calcification, RCA, calcification, stenosis, and this is, again, the RCA. And this patient, we didn't know which vessel was the culprit vessel, so we had to go on to actually a different study, a perfusion study. You can see it's the RCA, that's the culprit. So the answer here is CT FFR. So we are now starting to use CT FFR in the ED, and that's a whole nother topic, but it's a functional approach to trying to determine when you have stenoses in the mid-range, are they significant or not? And this is just another kind of fun case where the cause, so you can see this is an LAD. You can appreciate that there's some plaque here. It's non-occlusive. We would call it CAD-RADS1 perhaps. But the finding here is, in fact, that there is a bridge, a big myocardial tunneled segment. So this is diving into the myocardium. There's a perfusion defect, and this is causing the patient's chest pain, a rare cause of chest pain. Usually it's, atherosclerotic occlusive. Not in this case. It's actually due to this tunneled coronary artery, which is really an unusual. We see a lot of bridges, but we rarely see it cause symptoms. The practical aspects, I've sort of listed. Off hours, 24/7. You can't schedule this as an outpatient, unfortunately. And I've listed a few of the options. So we are fortunate to have trainees, and they will look at these different things. And depending on, if it's a negative, they will send the patient out. And if it's non-negative, then they'll hold, and we will generally look in the morning. That's still better than waiting in the morning till nukes, having a negative nukes, and then doing a PE study after that. So we're still ahead, even with the hold group. But at the very least, 50% are negative. That's pretty darn good. And this is just a meta-analysis looking at how good this technique is. And this is a mortality meta-analysis. And this diamond, without going into great detail, is showing that it is almost statistic. So this is CCTA, coronary CTA versus standard of care. And if this little bit of the diamond were a little further to the left in these meta-analysis studies, we would have a significant difference in the benefits of CCTA. We're not quite there. Maybe it's not powered high enough, but there's a trend in the direction of CCTA being beneficial from a mortality perspective, which is a pretty strong statement. All right, so I'm going to, as we get closer to the end of time here, just give a couple little other points. There are other causes which, one of which I'm going to talk about at great length tomorrow, which is aortic disease and aortic dissection. And in fact, I just as a note in this particular case, I want to draw your attention to what I call the dangerous diagnosis here, which is intramural hematoma. And this is a non-contrast study, and you can see this high-density crescentic abnormality in the ascending aorta. This should be a clue that you're dealing with an intramural hematoma, even if you don't get a contrast study. So that's a teaser for tomorrow. And then we can talk about a few other things, many of which are fairly straightforward. The one I want to mention just briefly here in addition is esophageal perforation, because I've seen this missed, unfortunately, more than one time. And so a lot of these occur, of course, the patients will come in with Boerhaave type syndromes, nausea, vomiting, and so forth. And you'll see, but you've got to look for not just, so at this point it doesn't look too bad, but you start seeing these bubbles around the distal esophagus, and distal esophagus is the place where this occurs most commonly, at least in my experience. And that's a sign, be on the lookout. And here you can, I think on the rightmost side, you can appreciate more bubbles, a little bit of pleural fluid probably as well, and some other stuff that doesn't belong. So anything in the distal esophagus that looks suspicious, think esophageal perforation, and be on the lookout of that. It can be a subtle diagnosis. Here it is again, just appreciating that doesn't look right. There's just all these bubbles outside the, and this is, it's not a common ER diagnosis for chest pain, but it is definitely one of them, and definitely a bugaboo. So I'm gonna throw that. And I like this case because, it's a chest pain etiology, and this is maybe the only case I've ever seen of this. So I put the arrow on the PE, but if you look closely, there's an aortic dissection here in the descending. And then if you look, there's also coronary disease. So this is my only example that I've ever seen of a triple rule-in. So I wanted to end on that note. So let me just conclude by saying, I think we've demonstrated very nicely here, imaging has a major role to play. It's essential to work with the ED for certain things. Certainly the whole chest pain thing that I was talking about, you've got to work with the ED, with the cardiologist, et cetera, et cetera. And then there's increasing functional kinds of things that we're doing in addition to the traditional anatomic of CT. Things like RV strain we talked about for PE and FFR CT that we briefly mentioned for the acute chest pain for coronary disease. And so with that, thank you very much. And I don't know when we take questions.